Hi everyone, this lesson is on Bell's palsy. So in this lesson we're going to talk about what are some of the potential causes for this condition. We're also going to talk about some of the pathophysiology behind why it occurs. We'll also talk about some of the signs and symptoms, how it's diagnosed, and how it's treated. So Bell's palsy is also known as idiopathic facial paralysis, or IFP. It is a condition involving unilateral paralysis of facial muscles, and it is actually due to facial nerve paralysis, which is cranial nerve 7. So it's paralysis of cranial nerve 7. We're going to talk a bit more about this when we talk about the pathophysiology later on in this lesson. In this facial nerve paralysis would be considered a lower motor neuron lesion. Now, the etiology as to why this condition occurs is not entirely understood, but there are a variety of potential causes, and we're going to get into all of those potential causes in the next slide. Bell's palsy is actually the most common cause of unilateral paralysis of the face, accounting for approximately 60 to 75% of cases. And the median age of onset of this condition is 40 years of age. Now let's talk about the potential causes of Bell's palsy. By far, viral infections have been more associated with Bell's palsy than other causes, particularly infections with herpes simplex virus 1 or HSV1. So this is the virus that causes cold sores. Another potential virus that has been implicated as a possible cause of Bell's palsy includes herpes zoster virus, or HZV. This virus is the cause of chickenpox and shingles later on in life. And with regards to these two particular viruses, with regards to how they actually lead to Bell's palsy, it is believed that these particular viruses may lead to Bell's palsy due to reactivation in cranial nerve ganglia. So these particular viruses can reside within cranial nerve ganglia or cranial nerve neurons, and their reactivation may lead to Bell's palsy in some individuals. Some other potential viral infections that may cause Bell's palsy include Epstein-Barr virus infections, cytomegalovirus infections, and infection with human immunodeficiency virus, or HIV. And there is some new evidence showing that infection with SARS-CoV-2, the virus that causes COVID-19, may also lead to or increase the risk of getting Bell's palsy as well. It also has been shown that certain vaccinations may increase the likelihood of Bell's palsy. Some other potential infections may also lead to Bell's palsy as well, and one significant one is Lyme disease. Now, in learning about Lyme disease, the mnemonic BAKE is used to help remember some of the clinical findings in Lyme disease, and the B in BAKE is Bell's palsy. And the other ones include arthritis, K for cardiac block, so K is used to help remember cardiac block, although cardiac is spelled with a C, and E is for erythema migrans. So these are the findings in Lyme disease. Other bacterial infections have also been associated with the onset of Bell's palsy as well, and these include the bacteria mycoplasma and syphilis as well. And then there is some association with certain autoimmune conditions. If you have an autoimmune condition, this may also increase your risk for having Bell's palsy as well. So those are some of the potential causes. Now let's talk about some of the risk factors and potential triggers for Bell's palsy. So one of the risk factors for getting Bell's palsy is older age. We mentioned that the median age of onset is 40, so it's going to be more likely to occur in older age adults as opposed to younger children, for instance. Diabetes is also another important risk factor. So diabetic patients are at a higher risk of getting Bell's palsy than non-diabetic patients. Pregnancy is also another risk factor, and particularly later on in pregnancy, in the third trimester, is when patients often will develop Bell's palsy if they are going to develop it. Obesity is another potential risk factor. This is associated with the diabetes, and hypertension is also another risk factor as well. Now, we can also see family history being a potential risk factor for getting Bell's palsy. So patients who have family members who have had Bell's palsy are at an increased risk for getting Bell's palsy themselves, although there's some question as to whether this is due to a shared environment or not. So family history does appear to be a risk factor, but it's not entirely understood as to how this may occur. There may be some genetic predisposition. And there are potential triggers of Bell's palsy as well. One of them that has been classically described is exposure to cold wind. More specifically, exposure to cold wind on one side of the face. So this has been classically believed to be a potential trigger of Bell's palsy. And then we mentioned that certain viruses are likely the cause of Bell's palsy. So a viral prodrome, meaning that there are symptoms of a particular viral infection, may also be a trigger that leads to Bell's palsy occurring. So some of the viral prodrome can be from HSV or herpes simplex virus, which would be a cold sore on the lip. And then another one would be upper respiratory tract infections. This has also been associated with onset of Bell's palsy after the upper respiratory tract infection has occurred. This also ties in with that possibility that there is a viral cause. And this also is something that is tied in with the fact that Bell's palsy is more common in winter months than it is in summer months. So all of these facts increase the likelihood that there is a viral cause that is underlying the onset of Bell's palsy. Now let's talk about some of the anatomy and the pathophysiology behind why Bell's palsy occurs and why some signs and symptoms occur from Bell's palsy. So cranial nerve number 7, or the facial nerve as it is referred to, is what is implicated in Bell's palsy. So this is what's going to be affected in Bell's palsy, and it's going to oftentimes affect one particular area, and that is known as the geniculum or the geniculate ganglion. And this is going to oftentimes be the main area where the lesion or the issue is going to occur. Now, the facial nerve branches into multiple areas that control the movement of the facial muscles and some other functions we're going to talk about in the next slide. So there are actually 5 branches of the facial nerve, which we're not going to get into in this lesson, but we will talk about some of the functions of the facial nerve in the next slide. But what I want you to take away is that there are multiple branches that lead to many different parts of the face, and we're going to talk about those in more detail in the next slide. So here is the facial nerve again. Here is the geniculate ganglion. This is where most of the issues occur in the facial nerve during Bell's palsy. And the facial nerve branches off to supply the muscles of the face to allow for facial expression. They also branch off to the lacrimal glands to allow for tear production or lacrimation. And they also branch off to the anterior 2/3 of the tongue to allow for taste sensation. And they also branch to the salivary glands to allow for salivation. And then there's also this other branch that branches off for hearing, and that is known as the chorda tympani. So all of these are branches of the facial nerve. And this leads us into the functions of the facial nerve, or cranial nerve number 7. These include muscle movements of facial expressions, as we mentioned before. We also mentioned that the facial nerve supplies and is responsible for the anterior 2/3 of the taste sensation on the tongue, and it's not responsible for the posterior third of taste sensation on the tongue. It's also involved in sound perception, as we mentioned before, through its chorda tympani branch, and it's also involved in salivation and tear production as well. So now that we know what the facial nerve does, and we know that the facial nerve is involved in Bell's palsy, but what actually happens to the facial nerve? Well, it's believed that the facial nerve in Bell's palsy becomes ischemic, edematous, or swollen, demyelinated, compressed, or has some other lesion or injury to it. And what is oftentimes going to be the site of the problem is going to be the geniculate ganglion. Now, other parts of the facial nerve may also be involved as well, and depending on where that lesion takes place, that will lead to particular findings, particular signs and symptoms. So what is believed to happen is due to some viral infection or reactivation of herpes simplex virus or herpes zoster virus, which have been found to reside in the geniculate ganglion. If there is some reactivation of those viruses, that reactivation may lead to some of these issues like ischemia, edema, demyelination, or compression of that area of the facial nerve. That may be the reason why we have issues of the facial nerve in Bell's palsy. And having some of those risk factors we talked about before, like diabetes or hypertension or obesity, they all seem to increase the likelihood of this happening in patients who have some viral infection or a reactivation of those viruses we talked about before. Now let's talk about the signs and symptoms of Bell's palsy. As mentioned before, this is a condition involving unilateral facial paralysis. Unilateral meaning that it is one-sided. It affects one side of the face. What's important to note here is that bilateral facial paralysis may occur in some patients with Bell's palsy, although this is going to be a rare occurrence. This unilateral facial paralysis is going to be acute. It's going to have an acute onset or a rapid onset that occurs within 48 hours. Oftentimes, patients may wake up with facial paralysis, and they can be quite startled by the facial paralysis that is so sudden. What's going to be noted with this facial paralysis is that it's going to lead to facial muscle weakness on the affected side, and it's going to include the upper and lower portions of the face, meaning that the forehead and the lower face are going to be affected. That's very important to make note of. The forehead is going to be affected in Bell's palsy. If it isn't affected, if it's only the lower face that is affected by this unilateral facial paralysis, that's more likely to occur with a central nervous system lesion or a stroke, for instance. So very important to make note of. The forehead or the upper portion of the face is going to be affected in Bell's palsy. With this unilateral facial paralysis, eyelid closure on the affected side may be impaired, and the affected side is most oftentimes going to be the right side. Around 60% of the time, it's going to be the right side of the face, and it's going to be ipsilateral to the lesion, meaning that it's going to be on the same side as the lesion of the facial nerve. So because it is a lower motor neuron lesion, if the right facial nerve is affected, the right side of the face is going to be affected, for instance. So it is ipsilateral. So as you can see in these images, it's important to assess for facial nerve functioning. So it's important to get the patient to raise their eyebrows, close their eyes very tightly, get the patient to smile, get the patient to show their teeth, and get the patient to blow out their cheeks. And those are important facial movements to assess for in assessing for functioning of facial muscles. As you can note here, the forehead is affected, so that's going to be something that is important to make note of in Bell's palsy. So as you can see here, the patient's left side of their face is affected, so they're not able to smile, and you can see in this image that they're not able to raise their left eyebrow. And oftentimes they may have issues closing their eye as well. And you can see there's some issue with this patient's ability to completely close their right eye. So those are important things to make note of as well. There may be numbness and tingling sensations on the face. This may be due to some co-involvement of the trigeminal nerve or cranial nerve 5. So some patients may have numbness or tingling sensations on their cheeks, their lips, their nose, or their mouth as well. Now, some other important signs and symptoms of Bell's palsy that may occur in some patients include ocular pain, blurred vision. Now, although a patient may have blurred vision, they're not going to have diplopia or double vision. If they do have double vision, that may be an indication of a central nervous system issue. So that is also something to make note of. Patients with Bell's palsy may have reduced or excessive eye tearing. They can also have taste disturbances. We mentioned that the facial nerve is responsible for the anterior 2/3 of the sensation of taste. They may also have decreased salivation. Patients with Bell's palsy may also have hyperacusis. Hyperacusis is due to the chorda tympani nerve branch being affected. So hyperacusis is a sensitivity to sounds. It makes the patient feel that sounds on the affected side are extremely loud. So that is hyperacusis, and that may occur with some patients. Some patients may also have otalgia. And some patients may also have mastoid pain. So the mastoid is behind the ears, and that may be painful in some patients. Some patients may have this mastoid pain that occurs prior to the onset of the facial paralysis. So that is also something that may occur as well. And there can also be some other posterior auricular pain that may occur. How is Bell's palsy diagnosed by clinicians? It's going to be important to do a clinical examination. So a cranial nerve examination along with looking at the eyes, looking at the ears, looking at the mouth are going to be important. And as mentioned before, a cranial nerve examination is going to be important. So assessing the facial nerve functioning. So by doing those facial movements that we talked about before, it's important. Clinicians may also do a stapedial reflex test, which may be absent in some patients with Bell's palsy. So those are going to be important tests to employ for a clinician, but there are actually no specific diagnostic tests for Bell's palsy. But because of some of those risk factors we talked about before, including some of those viruses we talked about before or other infective causes, it's important to look out for those. So Testing for HIV, syphilis are going to be important, and looking out for diabetes in patients who don't have a diagnosis of diabetes because they are at an increased risk for Bell's palsy. That may be something that is important to look out for as well. A Schirmer's test can also be helpful in supporting the diagnosis if there is some question. A Schirmer's test is for assessing the tear production of the eye. It's also important to exclude other possible causes of symptoms, especially if there are particular findings that may be suggestive of a stroke. Again, if the forehead is not involved, if it is a slower onset. So again, we talked about Bell's palsy occurring rapidly. So there's a sudden or rapid onset of symptoms. If it is a slower or progressive onset, that is more indicative of a stroke. And if there are some of those other findings we talked about before, if there's double vision or some other finding that may suggest a central nervous system lesion, that's important to look out for. An electroneurography may also be used to assess the affected side of the face as well, and this can be used at day 3 to 14. This is going to be helpful in prognosis and in deciding some potential treatments we're going to talk about in the next slide. Bell's palsy is going to be a clinical diagnosis, and more specifically, a diagnosis of exclusion. So excluding other potential causes of the facial paralysis is going to be required for making the diagnosis of Bell's palsy. But some potential diagnostic criteria for making the diagnosis of Bell's palsy include having all facial muscle groups being affected. So again, the forehead and the lower face being affected. It is going to have a rapid onset, so that facial paralysis is going to occur with a rapid onset within 48 hours. And there's no central nervous system findings, so those are going to be key important criteria for Bell's palsy. And then there is a severity scale for Bell's palsy by House and Brackman. There are 6 grades of severity. Grade 1 is where there is a normal facial function. Grade 2 is mild dysfunction. Grade 3 is moderate dysfunction. Grade 4 is moderate to severe dysfunction. Grade 5 is severe dysfunction. And grade 6 is total paralysis. So there is this scale as well for making an assessment of the severity of the facial paralysis. Once clinicians have diagnosed this condition, how do they treat it? Bell's palsy is often a self-limiting condition, so even without treatment, it can spontaneously resolve on its own in the majority of patients. In fact, it actually gradually resolves in 80 to 90% of cases. So majority of cases are going to have a resolution of Bell's palsy between 6 weeks and 3 months. And the resolution often begins within 3 weeks. Now, if there is no improvement of symptoms until later, if it takes many months to actually see some improvement of symptoms or findings from Bell's palsy, it's less and less likely that there will be resolution, or less and less likely that it will be a complete resolution of symptoms. And there can be some recurrence of Bell's palsy in certain individuals. Up to 8 to 12% of patients with Bell's palsy will have a recurrence, either on the same affected side or the opposite side of the face. And this is going to be more likely to occur in patients who have a family history of Bell's palsy. So this is something to make note of as well. And with regards to who will be more likely to resolve or have a complete resolution of Bell's palsy in comparison to those who won't have a complete resolution, it has to do with those risk factors we talked about before. If patients have diabetes or are obese or have hypertension, they're more likely to have long-term issues. They're more likely to not have a complete resolution of symptoms, whereas patients that don't have those risk factors are more likely to have complete resolution. Now, although we said that patients may resolve on their own without treatment, corticosteroids can be helpful in some patients, so this includes prednisone. If it is a severe case of Bell's palsy, there is severe dysfunction, then antiviral medications, for example, acyclovir, can be helpful in treating those patients. In supporting the patient through the resolution, eye treatments can be important. So for instance, in patients who have reduced tear production, topical lubricants will be important to help reduce the risk of complications of corneal abrasions, for instance. And in some patients, surgery may be required. Surgery is going to come down to the electroneurography findings. So if there is 90% or greater nerve degeneration found on the electroneurography, that is going to be an indication for surgery. Some of the surgeries that can be employed include facial nerve decompression, facial nerve grafting, eyelid surgery or tarsorrhaphy that can be used to help with issues with closing of the eye, and a brow lift may be required for some patients as well. So these are potential surgical methods that can be used in some patients with Bell's palsy. And again, these are going to be in those with 90% nerve degeneration on electroneurography. If you want to learn more about other neurological conditions, please check out my neurology playlist. And if you haven't already, please like and subscribe for more lessons like this one. Thank you so much for watching, and hope to see you next time.